Hi, my name is Ryan Wolsky. I'm a first-year internal medicine resident at Advocate Christ Medical Center, and today I'm going to be presenting this interesting case of spontaneous coronary artery dissection and how we think that we could have avoided all these complications of the procedure for which this patient received had she been screened with a coronary CT angiography instead of being taken right to the cath lab. So to give you a bit of a background, the definition of spontaneous coronary artery dissection is when there's separation of the walls of the epicardial arteries, and that can often cause the artery to become occluded and result in infarction of cardiac tissue, or sometimes it can also rupture and lead to tamponade. Although SCAD is an uncommon finding in hospitalized patients, it makes up a very high proportion of young females who present with myocardial infarction, so it's still very important to diagnose. And as we'll see in this patient's case, she was a young female with no pre-existing conditions. So jumping into our case description, we had a 30-year-old female, no past medical history, no family risk factors, not taking any medications. She presented with typical chest pain complaints, headache. We admitted her, did an EKG, as well as took a troponin. The EKG did not show STEMI, but did show T-wave inversion in leads 3 and V1. Her troponin was 5.3, so she was diagnosed with an N-STEMI. She was actually taken to the cath lab the next day because she was hemodynamically stable, and in the cath lab, they did left-sided angiography. Initially, the left side was patent, but when the diagnostic catheter was removed, she became very bradycardic. So they went back into the left side and obtained the image that we see here in figure 2, where there was obstruction. The cardiologists were able to dilate the artery and episodically improve the blood flow, but it would open and close and open and close. They could not maintain its patency. And as we see in figure 2, it had the angiographic appearance of spontaneous coronary artery dissection. As the case progressed, the patient ended up coding and required CPR. They rushed the patient to the operating room where she required 2-vessel salvage coronary artery bypass grafting. And she was later placed on ECMO, and she ended up needing a heart transplant on hospital day 64. Her hospital course was very complicated. She had several post-catheterization complications. She had several intra-abdominal infections. She had a stroke. She ended up needing a splenectomy, and we're arguing that this whole course could have been avoided had she been screened differently. So in the discussion section, I discuss about how it's very important to diagnose SCAD and make sure that it's diagnosed differently than thromboembolic occlusions because the two are managed differently. SCAD often resolves on its own, so its management is often conservative, whereas thromboembolic coronary occlusions are managed with stenting and with invasive angiography. Currently, according to the literature that I saw, the gold standard for diagnosis of SCAD is still invasive angiography supplemented by ultrasound. However, it's not stented; it's managed very differently. Our argument is that if these patients who are hemodynamically stable, who are atypical coronary disease patients, such as this patient who's young, does not have atherosclerosis, not on any medications, not on any oral contraceptives, for these patients who are hemodynamically stable, we could have avoided this whole complicated course had we screened her with a coronary CT angiography non-invasively before going right to the cath lab. So that's kind of our argument here. And in conclusion, if we have these patients who are atypical coronary artery disease patients, our clinical suspicion needs to be high for other disease etiologies. And in patients who are hemodynamically stable, maybe we should consider looking at them with a coronary CT angiography instead of other invasive testing modalities.